So let's go on with the first question for today. A new echogenic needle is designed to improve visibility during in-plane ultrasound guidance. Which design feature most increases visibility across varying needle angles? Okay, so basically I hope you guys know that now you get these new kind of needles. They are called as echogenic needles. Okay, now what these echogenic needles do is that as compared to other needles, like generally initially what people were using for the blocks were your normal needles that we use, the infiltration needles, or people were trying to use the spinal needles for giving the blocks. Okay, but the visibility of the needle was not very good under ultrasound guidance. It is very important that you see where your needle is going, that you are not going into the nerve as compared to staying around the nerve perineural area, and also to see the path of your needle. All right, and this makes giving the block much easier. So nowadays we have these echogenic needles. Now the good property or the important specific property of these echogenic needles is, I'll just show you the picture. So as you can see, they have this kind of dimplings or serrations. Okay, you can see over here, they have these small dimplings, serrations, or in other words, this part of the needle is quite uneven. Okay, now why is it uneven? It is so that whenever the ultrasound beam is reflected onto the needle, it reflects back, and when it reflects back easily, then you get a better picture of the needle. Okay, see, you need the ultrasound waves to be coming back to the transducer so that the transducer can create an image, and it will come back only if your surface is not very clean and polished. If your surface is very clean and polished, then the waves are not reflected back. But if your surface has these serrations or dimplings, then these ultrasound waves get reflected back and you get a very good picture of the needle. So this is the property of the ultrasound echogenic needles. So option A, they have a polished stainless steel surface. No, in fact, that is something that we don't want, a polished stainless steel surface. They have a corrugated or dimpled needle tip. Absolutely right. So they have a corrugated tip, as you guys saw. And they have beveled long cutting tip. No, just the tip does not matter. And the bevel does not really make much of a difference to the ultrasound picture, and it has a standard 2-Hoy curvature. So standard 2-Hoy curvature is required in epidural needles, not a specific property of your echogenic needles. Okay. Now in epidural, you know that we use a 2-Hoy needle. The 2-Hoy needle, it actually has a slight bend if you see at the end. The reason why this 2-Hoy needle has a slight bend is so that you don't puncture the durameter. Okay, now you want that the 2-Hoy needle stays in the epidural space. Okay, you don't want it to puncture the dura. So if you don't want it to puncture the dura, what this needle has is the slight bend or slight curve at its end, so that it pushes the dura and the dura does not get punctured. Otherwise, this will end up causing a dural puncture during the epidural, leading to post-dural puncture headache in the patient. Okay, so D is the standard 2-Hoy curvature is this, which is seen in epidural needles. But we don't need it in echogenic needle. So that is also not the option. So the correct option is option B. Okay. Then we go to the next question. During epidural catheter insertion, resistance is encountered after 3 centimeter of catheter advancement. Which catheter design characteristic most reduces such coiling or kinking? Now, this is a very practical question. A lot of us have put epidural day in and day out. And initially, when you were putting epidural, remember, we used to force the catheter in. And our seniors used to always say, don't force the catheter in. Why? When you force the catheter, all it does is that it kinks or it coils inside. If it kinks means it bends. If it bends, whenever you give the local anesthetic into the catheter, it will not reach into the epidural space. Okay. If the catheter coils, the catheter can end up migrating outside the epidural space. Okay. So you don't want to force the catheter inside because that causes kinking or coiling of the catheter. Now, how do I prevent this coiling or kinking? That is the main thing. How do I prevent the catheter from coiling or kinking? And it should go straight into the epidural space very well. So for that, what we do is we use these catheters which are multi-orifice. They are stiff. Now, why are they stiff? They are stiff, and if they are very flexible, then they can coil easily. Okay. Or they can also kink or bend easily. But if they are stiff, then they don't kink or coil easily. Now, how do you make these catheters stiff? You do a wire reinforcement inside them. What is a wire reinforcement? So I'll just show you the picture. If you see over here, there is a small thin wiring that you see along the catheter only, and this helps in maintaining the shape of the catheter, prevents the coiling kinking, and keeps the catheter stiff. Okay, so this is called as wire reinforcement of the catheter. Now, what is multi-orifice and single orifice catheter? Okay, so now if you see an epidural catheter that on its tip it has an opening, only one single opening, we will call this as a single orifice epidural catheter. But if you see another catheter, the tip is blind, that means the tip is closed, and on the side you have these openings. Typically, we have about 3 openings on the side at 0.51 and 1.5 centimeter from the tip. Okay, so this is called as a multi-orifice catheter. It is seen that multi-orifice catheters help in distribution of the drug much better as compared to single orifice catheter. So what we prefer nowadays in the epidural space is the multi-orifice stiff catheters with wire reinforcement. Okay, now next question. A resident prepares equipment for a combined spinal epidural using the needle through needle technique. What is the key design property of the spinal needle used in this system? Okay, now what is this needle through needle technique combined spinal epidural? So all of us in our residency have used this set. What is this set? Is if you want to put epidural plus give spinal in the same patient, you have 2 options. Okay, one is, let's say the patient is sitting, and what you do is you put the epidural catheter at one level and then you give the spinal at the other level. Okay, so that is your option number 1 that you have. You give the spinal and the epidural at 2 different levels by following 2 different techniques. Okay, option number 2 that you have is that you use a combined spinal epidural technique. In combined spinal epidural technique, what you do is first you put the epidural. Okay, in the epidural, you find the epidural space, and what you do is that once you find the epidural space, you will not put the catheter inside immediately. Okay, you'll just find the epidural space, and through the epidural needle, you will advance the spinal needle. Okay, now this spinal needle is thin, it's long, and most of the times it has a single pencil point. Okay, now this spinal needle will go, it will advance beyond the epidural needle and it will go into the subarachnoid space. And this is where, when you see CSF coming, you know you have reached the subarachnoid space. Now what you do is you give your spinal drug. Once you have given your spinal drug, then you take your epidural catheter. If you remove this needle or the epidural needle that, sorry, the spinal needle that you had put. Okay, just keep the epidural needle, and now you will thread your catheter inside this epidural space. Okay, so once your spinal anesthesia is given, then you remove the spinal needle part and you thread your epidural catheter. Okay, now you keep this epidural catheter inside for the use of the rest of the surgery. So this one is called as the combined spinal epidural technique. This is how the combined spinal epidural set looks like. If you see, this is your epidural needle. This is your spinal needle. Now here, the spinal needle that you're seeing should be such that it should be able to, it should be long and thin, and it should be able to go through this epidural needle. Okay. And this is your epidural catheter that you will put in the end after giving the spinal. Okay. This is your filter, as you all know, filter and connector. Okay. So these are the things that are present in a combined spinal epidural set. Now, they are asking, what is the key design of the spinal needle used in this combined spinal epidural technique? So as I told you, we just want a long, thin spinal needle that will fit through the epidural needle. Okay. So option C, long, fine gauge. Fine gauge means thin spinal needle compatible with the Tuhoy lumen. That is the epidural needle lumen. Okay. Let's look at option A. Do you need a pencil point needle? Okay, you can use a pencil point needle. Pencil point needle is like this. Okay, you can use it, but you don't need a large side port in this needle. No, that is not required. Okay. Do you need a short wide bore cutting spinal needle? No, we can't use a short needle because when we are putting the spinal needle through the epidural, okay, this is your epidural needle, Tuhoy needle. You need to have a long needle. Okay, you can't have a short needle, otherwise it will not go beyond your Tuhoy needle. Okay. Option D is curved needle designed for catheter placement. Okay, so we don't use a curved needle. Why? Because you want something that will go through the epidural needle and it will pierce through it and it will go into the subarachnoid space. Typically, this curved needle is nothing but a definition of your two-Hoy needle. As I told you before also, the two-Hoy needle is slightly curved so that it can push the durameter and prevent the dural puncture. Also, catheter placement is done by an epidural needle, not by a spinal needle. Okay, so this is not the key characteristic of the spinal needle. This is in fact the key characteristic of the epidural needle that we'll use in the CSE set. Okay, next. For a femoral nerve block, a nerve stimulator is used. Which parameter most accurately indicates that the needle tip is optimally close to the nerve? Okay. Now, this is very important for you guys to understand. Whenever you are using a nerve stimulator, there is a general principle that you have to follow. Okay. Generally, what we do is that we start the current at about 1 milliampere. Okay. And we look for the twitches of the muscle depending on what is the nerve block that you are giving. For example, if you are giving femoral nerve block, okay. Now, if we are giving femoral nerve block, we will look at the twitch of the quadriceps muscle. The quadriceps muscle which inserts at the knee, okay. So, you will see the quadriceps twitch. It is also called as the patellar dance. Okay. Now, if you're able to see this patellar dance at 1 milliampere, what you'll do is slowly reduce the current. You reduce the current up to 0.5 milliampere. You can still see the quadriceps twitch. You go down to 0.2 milliampere. Okay. And you are still able to see the twitch. If you go down below 0.2 milliampere and the twitch disappears, that means that you are in the correct place. You're close to the nerve. You're not inside the nerve. Remember, block always has to be given close to the nerve, not inside the nerve. If you're going to go inside the nerve, you're going to cause nerve damage, and that could be permanent nerve damage as well. Okay. So you want to make sure that your quadriceps twitch is maintained when your electric current is between 0.2 to 0.4 or 0.5 milliampere. Okay. Now, this is the answer over here. Suppose your quadriceps twitch. Suppose your quadriceps twitch is continuing when you go below 0.2 milliampere. Okay. If below 0.2 milliampere also your twitch does not disappear and your twitch continues. If your twitch continues over here, that means you are inside the nerve. Okay. That means you are inside the nerve and this is not where I will want to give my block. Okay. So I need to withdraw the needle slightly. Suppose your twitch, so this is what is written over here, all right? Now, suppose your twitch disappears when you go between 0.5 to 1 milliampere. So, if your twitch disappears when you go below 0.5 milliampere, that means you are far away from the nerve. You're far away from the nerve. Okay, so ideally to get an ideal response, your twitch should remain when your current is between 0.2 to 0.5 milliampere. Anything below this, twitch is still continuing, you are inside the nerve. Anything above this, your twitch is not coming or it's coming and going, that means you are far from the nerve. Okay, so this is what you need to remember.